This is a minor adaptation of what Chris Wilde said in 2005. Exposome is every exposure to which individuals are subjected from, I'd say, preconception to death. So you could think of the exposome as everything, everywhere, all at once. Is it everything? Well, yes, except genetics. Is it everywhere? Geospatial is important. Is it all at once? Well, not exactly, because temporality is key. It involves multiple domains. We heard one rubric that Paul said. Another one is ecosystems, lifestyle, physical, chemical, social, and omics. Or another way to look at this is specific external environment, which tends to be our individual kind of variables, our general external environment, which tends to be more upstream, our internal environment, and how these things overact over time, the life course dimension, to yield health risk and impact assessment. Well, however you define exposomics, it's true that there's been a lot more attention to it worldwide, as you can see this upward curve in the exposome publications per year. And there have been a number of initiatives that you see along this graph. Two of them I want to point out are the Exposomics workshop series that NIEHS put on a couple years ago, and then tell you a little bit about the ECHO program. So just one slide about the workshop series. They identified 5 areas and 10 priority topics to operationalize exposomics, including what to measure, how to measure those variables, how to share and harmonize data, integrating, analyzing, and interpreting the data, and translating it for influence. And most of my comments will sort of be on the writer's side of this continuum. So what's the ECHO program? Environmental Influences on Child Health Outcomes. Our mission is to enhance the health of children for generations to come. And we do this through observational and intervention research, observational in the ECHO cohort. We also have an intervention network that covers together all 50 states, DC, and Puerto Rico. And we look at 5 key pediatric outcomes with high public health impact: pre- and postnatal outcomes, upper and lower airways, obesity, many facets of neurodevelopment, and positive health or well-being, singly or in combination. Today I'm going to concentrate on talking about our observational work, the ECHO cohort, where exposomics will come to the fore. And in our ECHO cohort, we take the view that a good start to life can last a lifetime and over generations. And we say to ensure a good start, we need to understand potential risks and resiliencies. These are the environmental factors. And we need to understand when and to whom they apply so that we can inform policy, program, and practice. And this is what we call solution-oriented research, research in observational and intervention work that informs programs, informs policies like state and federal policies, programs like public health programs, and practice like clinical practice guidelines. So with that in mind, the overall goal of the ECHO cohort is to answer solution-oriented questions about the effects of a broad range of early environmental exposures on child health and development. And our view of the exposome, our broad range of early environmental exposures, is that they range from society to biology. So not just physical and chemical, but also societal, medical, psychosocial, behavioral, biological. In our exposure period, we focus mostly from preconception to age 5. And why is that? Why preconception, pregnancy, and early childhood? As we know, these early exposures can have less lasting effects because development is a highly integrated process and a sensitive time for exposure for all of these reasons that you see on this slide. And this paradigm of early exposures leading to later life consequences is called developmental origins of health and disease, which you'll hear about some more in our second talk. Well, just to let you know about the ECHO cohort, our investigators have devised a data platform that now has data from over 100,000 participants from 70 pre-existing ongoing longitudinal maternal child health studies. It also has assay data from biospecimens, newly assayed biospecimens, a growing biorepository, and there's been lots of productivity from our investigators over its first 7 years. And this is because we've developed this nationwide echo cohort that's quite diverse in terms of age and sex and SES and race ethnicity. We've just started our second 7 years, lasting until 2030, in which we're extending and expanding the echo cohort. And the new thing we're introducing now is a preconception phase to our cohort. So we'll have a large, diverse cohort from preconception through adolescence, with more than 30,000 kids in follow-up and new pregnancies totaling over 30,000 as well. And our exposome data will come from a standardized data biospecimen collection protocol, which is longitudinal and multi-generational and includes primary data, secondary data, and biospecimens. So there's lots of opportunity for exposome research within ECHO. And I wanted to point out to you all that the data, the de-identified data from already collected data in ECHO in the cohort is now available through a controlled access public use database on NICHD's data and specimen called DASH, where access requests undergo administrative review. So now we have data on more than 63,000 participants, and it's available to all of you, the broader research community, for analyses. Okay. So now I've talked a little bit about what Exposomics is, the ECHO program, and what some of the opportunities are. What are some of the challenges? Well, I talked initially about prediction versus explanation or etiology. So let me go into that just a little bit more. So most of Exposomics today has been used for prediction. So we use values of all relevant variables to make predictions about individuals or populations. And in prediction, we can use non-modifiable as well as modifiable determinants. And in the next bullet, you see some of the measures of effect that we talk about in prediction. So here's a recent example from ECHO. This is about 10 ECHO cohort studies. And they asked the question, okay, if you measure 6 different variables in the first 3 years of life, how well can you predict that somebody will develop asthma by the age of 7 years? And with these 6 variables you can see on the left-hand side, you can develop a 14-point risk score. And as you can see, some of these are non-modifiable, like parental asthma and African American race, and some might be more modifiable. Well, it doesn't matter, because if you're trying to predict, you can use all of those variables. And you can see the area under the prediction curve here is 0.76. And what that means is that you can divide people, you can categorize people into low risk or moderate risk or high risk, depending on how many points they get on this scale. And so that tells you, okay, so which kids you might intervene on, but it doesn't tell you how to intervene. It doesn't actually give you a solution. And now we have many more high throughput approaches, so that we're not looking so much at 14 variables anymore. We might be looking at 100 variables or 1,000 variables. And they might be biomarkers, and they might be high throughput omics. And I'm really happy to say that the new laboratory core for ECHO and Cycle 2 is right here in Nashville at Vanderbilt, and it's going to help us with this. So we can look at many, many exposures simultaneously. And why is this good? Why is this a good thing? This is a pro because people are exposed to many exposures simultaneously, and new techniques allow us for innovative analyses. But some of the cons are, sometimes it's hard to choose the best technique, and we may be still confusing prediction with etiology. So let me take that first one and say, a lot of people have been interested in looking at mixtures of chemicals. So chemicals not at one at a time, but many at a time. That's what people are typically exposed to. We're not exposed to one chemical at a time, we're exposed to mixtures. But how do we analyze those mixture models? Well, many statistical models exist. Each one of these nodes is a statistical model to look at chemical mixtures. And you can imagine it's a challenge to choose the best one. It can rely on what the type of research question is. So each of the different colors here is a different type of research question. The amount of data, the data structure, the study design, etc. So even choosing the right approach to exposomics data can be difficult. One of the great things about the new artificial intelligence approaches like machine learning is we're getting better and better exposomics prediction. So machine learning algorithms can generate data clusters by finding connections that investigators may not have expected. So this is really a great advance in prediction. But when we think about big data, and we have a lot of statistical power, we have to have great responsibility. And one of those responsibilities is to ask whether prediction is really helping us with solutions. Is that the sweetest spot for child health solutions? What I'm not going to talk about today, which is extremely important, and I think will come up in the rest of the symposium, is the quality of the data and the equity in the data. These are really important things. That's not what I'm addressing right now. My point is that as we get more and more exquisite data analysis techniques for the kind of data in exposomics, we tend towards the biological, the reductionistic, the individualistic. And it makes us think about medical models. Oftentimes when we think about the biology, people say, well, we should develop a drug to change the biology. But are drugs really where we want to go with pregnant people and young children? Probably not. So to drive solutions, let's consider etiology in addition to prediction. Let's look at modifiable causes. This is where our solutions come from. Let's focus upstream, above the skin. So primary prevention is once people have risk factors, how do you prevent disease? Primordial prevention is preventing risk factors from appearing in the first place. And let's think about intervening among groups or subpopulations, not just among individuals, where we get more bang for the buck. And when we think about precision medicine and child health, then oftentimes we're thinking about prevention more than treatment. We're invoking above the skin as well as below the skin factors. So these are behavioral, psychosocial factors in addition to omics. And the tailoring or the precision can be not just about individuals, but about subpopulations like families, like neighborhoods, like larger communities. So when we think about the other purpose of observational research or explanation or etiology, what we're trying to do is describe unbiased, perhaps causal relationships between exposures and outcomes that are independent of other exposures, especially independent of what we call confounding factors. And what we're trying to do is have our statistical models follow our conceptual causal models, otherwise known as directed acyclic graphs or DAGs. And some of the measures, the typical measures of effect you can see in the bottom bullet on this slide. So let's take another example from ECHO and see how that plays into etiologic or solution-oriented thinking. And this is a study that was published now a few years ago about disparities in asthma incidence. So most research on the frequency of asthma before this study focused on prevalence, not incidence, whereas incidence data, that is who gets the disease, not who has the disease, can reveal more about etiology. And in this study of 32 ECHO cohort sites with over 12,000 participants, you can see that on the left, whether there was no family history of asthma, or on the right, where there is a family history of asthma, that Black children had higher asthma incidence than white children in early childhood. So if the incidence rates are different in early childhood, that implies that something is going on at birth or before birth that may be driving these disparities. Yes, so we're suggesting prenatal determinants of disparities in asthma risk. And the question is, could air pollution be one of those determinants? It itself is socially patterned. And through geospatial approaches, looking at place and time-based exposures, our investigators have suggested that that is true. So either PM 2.5 or actually smaller particles, ultrafine particles, in late pregnancy seem to be associated with the incidence of asthma in the first few years of life. So childhood asthma is related to prenatal air pollution exposure. It may help explain early childhood racial differences in asthma incidence. So we're not just describing disparities, we're getting behind them to explain them and look for solutions. And these small particles may lead to new regulations because they're not as regulated as the larger particles are by the EPA. So there's a solution for you. And when we're thinking about causal inference in observational studies, we often do multivariable analyses. Well, let's think about doing multivariable analyses that match conceptual models in areas of covariate overlap. And let's look for other tricks of the trade in observational studies that help us with causal thinking, whether that be cross-cultural comparisons or negative controls or twins and SIB pairs or instrumental variable approaches like Mendelian randomization, like biological plausibility, looking at mediation analyses, so-called mechanisms, or natural experiments. And when we have more than one of these types of studies that yield similar findings, then I think we can be a little more sure about causality and then looking for solutions. Just thinking for a moment about our multivariable models, machine learning tends to put lots and lots of variables in the same model. And why can this be a challenge? Well, let's go back to a very simple approach and thinking about models in epidemiology. On the one hand, if we have exposures and outcomes on the left side, and we have other variables that are related to both exposure and outcome, so-called confounders, we want to adjust for them. We typically might be overestimating the result, the relationship between an exposure and an outcome if we don't adjust for a confounder. On the other hand, on the right-hand side, if we're interested in exposures and outcome, but there's a mediator, the exposure actually causes the mediator, which causes the outcome, then if we adjust for the mediator, we might be underestimating the total causal relationship between the exposure and the outcome. And mathematical models don't distinguish them. Let me give you a very simple example. Suppose you're interested in the relationship between gestational diabetes and childhood obesity. If you don't control for maternal obesity, you'll be overestimating any causal relationship between GDM and childhood obesity. On the right-hand side, though, if you're interested in whether maternal obesity causes childhood obesity, if you control for gestational diabetes, you might be underestimating the total causal effect of maternal obesity. So this is just with 3 variables. You can imagine if you have 100 or 1,000 variables in a model, it would be very hard to distinguish between confounding and mediation. Scientific judgment is needed. So with exposomics and causal inference, are there approaches coming? Well, here are some titles of recent articles about causal effects of interventions in early life environmental exposures, machine learning and precision medicine, machine learning and causal inference, in silico models like agent-based modeling, integrating machine learning and agent-based modeling. Most of these articles will tell you, however, that we're kind of in our infancy in figuring out how to incorporate artificial intelligence and machine learning into our causal reasoning. And I thought this quote was nice. So, although machine learning tools can be beneficial in identifying empirical associations among large numbers of covariates, empirical associations by themselves are not sufficient. We emphasize the importance of using substantive knowledge to obtain an understanding of the data and the underlying causal structure before applying ML procedures for confounding control. ML procedures should not replace background knowledge, but should be used to complement investigator input when controlling for confounding. So let me just bring it home with an example that I think has been recalcitrant in medicine and public health, and that is preterm birth. Preterm birth rates have hardly changed over many decades, and disparities in preterm birth, racial disparities in preterm birth, are recalcitrant. Lots of people have been looking at downstream determinants of preterm birth and disparities in preterm birth, whether they be these biological mechanisms that you see in the second to the right column, or even the downstream causes where we've tried lots of individual level behavioral changes, but they don't really seem to work. And so when we're looking for solutions to these disparities in preterm birth, and this will apply to other conditions as well, we really need to look at these midstream and upstream causes. And the issue right now is that I think more measurements obtained from the downstream and from the biological. We need more measurements in the upstream so that we can drive solutions. So here's what I said. Exposomics is really compelling, especially for prediction. It takes advantages of many technologies, and it's exciting, and I think will help us greatly here. To drive solutions in child health and in maternal child health and the developmental origins of health and disease, we need to put exposomics into causal frameworks. We need to collect modifiable upstream measures, and we need to consider precision prevention among populations. As Nancy Krieger and George Davey Smith said, data never speak by themselves, either to computer algorithms or to people, and nor do beliefs about probabilities simply drop from the sky. Active scientific judgment is inevitably involved. Thank you very much. I'm happy to answer questions.